Good afternoon, distinguished guests, ladies and gentlemen. Welcome to the delegation of the Ismailia Mamad. My name is Sofia Jadavji, and I'm a Monitoring, Evaluation, Research and Learning Manager here at the Aga Khan Foundation, Canada. We are delighted to have you here today, both in person and those of you who are joining in online. Welcome. For those of you who are here for the first time, this building was opened in 2008 by His Highness the Aga Khan. Since then, it has been the headquarters of the Aga Khan Foundation, Canada. It was opened in the spirit that this space be used to lift our collective horizons for how we might all contribute to a more pluralist, peaceful, and prosperous world. It was also the intention of this building to offer new platforms for the exchange of ideas, to stimulate intellectual discussion, collaboration, and reflection on Canada's role in the world. We are thrilled to have with us here today Thomas Shupin from the Abdul Latif Jamil Poverty Action Lab, or JPAL, at MIT, to continue the discussion we started earlier this year with Iqbal Dhaliwal on Can Randomized Controlled Trials, or RCTs, Transform Development. Today, Thomas will focus on assessing the evidence from randomized evaluations of economic interventions in health. This event marks the third of our ongoing series, Measuring Development Impact. The series, undertaken with financial support from Global Affairs Canada, aims to connect the Canadian international development community with global monitoring and evaluation practices and expertise, bringing in specialists at the forefront of new and innovative methodologies to help inform and strengthen our own Canadian practices. To date, we have been fortunate to have had some very high caliber and internationally recognized speakers sharing their vast knowledge and expertise with us. If you missed any of the previous sessions, I strongly encourage you to visit our website to view the webcast recordings. When Iqbal Dhaliwal was here back in February, he provided a very compelling case for RCTs, outlining the strengths of the approach, but also not shying away from some of the limitations. It is no surprise that RCTs have generated a lot of interest in the development sector, from practitioners to policymakers alike. Since 2003, JPAL has conducted hundreds of evaluations, generating a wealth of evidence across the sectors which policymakers could and should use, both in the developed and developing countries. Today's focus on health responds to a sustained demand from the Canadian international development community to learn from the evidence to help inform our programming. Canada is a leader when it comes to global health, particularly through the Muskoka Initiative, focusing on maternal, neonatal, and child health. Countless Canadian organizations are working to improve access to and quality of health care. Today, we have an exciting opportunity to hear from Thomas, Policy Manager with JPAL, to hear the evidence gathered through RCTs in the health sector. His bio is on your chairs, and you could also see the bio on the AKFC and JPAL websites. Following Thomas's presentation, we'll open up the floor to questions, comments, and discussion from the group here in the room, as well as those who are online. Please join me in welcoming Thomas.
Can you hear me? Yes? Good. All right, wonderful. Thank you very much, Sophia, for that very kind introduction, and to everybody at the Aga Khan Foundation Canada for being so hospitable. I was going to mention that I've been here in Canada for 2 days, and I think I've fully acclimated to random people coming up and saying hello and asking how I'm doing and making small talk. So thank you for being so warm. And secondly, thank you for coming today, because it's a beautiful day outside, and I live in a relatively similar climate, and I know what the temptation is like to just keep walking after you leave your office and enjoy the day. So we have an hour and a half together, and I'm going to try to limit my presentation to just 1 hour, so we have plenty of time for a discussion about the evidence. And some of you have attended or seen the presentation that was given by my deputy director in February, which provided an overview of JPAL. But for those of you who haven't, I thought I'd start today with a short introduction to the organization and our work, and then move into the evidence that just goes across 6 different themes, and give you some illustrative examples of each policy lesson that's coming out of the evidence, and then open it for discussion. So this is the outline, and I thought I'd start with an introduction to JPAL. So at its core, JPAL is a research center in the economics department at MIT. And at its heart and core are the researchers themselves, a network of 135 professors from over 40 different universities around the world. And what unites them is the use of randomized controlled trials to measure the impact of social and economic development programs. And that is their unifying piece of work. And the reason that they choose this methodology is because of its technical power in trying to assess and estimate the attribution of the impact of a particular program. So many of you are very familiar with this methodology of randomized controlled trials, but for those of you who are not, the idea in its simplest form is that you would take a universe of individuals or some other type of unit like a health clinic or a village, and then you would divide them up into 2 different groups. One group would receive an intervention, one group would not. You would have, therefore, a treatment and a control group. And sometime after the intervention or periods thereafter, you could then measure the outcomes of interest and determine from that a very clear causal impact of the effect of your program. What is so beautiful about this methodology is if the study is designed and implemented very well, then they are statistically identical, these 2 groups, on every characteristic, both those that you can see and those that you cannot see. And they always will be long into the future. So you can determine the long-term impacts of even a very short-term intervention. Now, the organization itself is organized across 3 pillars. The first and most important, of course, is the research, the impact evaluations themselves. But also, the reason the organization was set up was basically to try to turn evidence into policy action. And with that, we set up this policy group where I sit. And our job is to do exactly what we're doing today, to work with policymakers like yourselves to help them understand the evidence that's been generated, distill some of the policy lessons, and work with you to integrate the evidence into your programming so that we have better development outcomes. The third arm is really about training, building up the capacity of policymakers here and practitioners everywhere to understand how to consume evidence in a more sophisticated way so they have better policy decisions. Now, this is the scope of our work. So this is a map of all the evaluations that are ongoing or completed around the world, of which there are more than 800. And at the bottom, if you can see, there's a legend that shows that this work is in 8 different sectors. So I have colleagues that manage all of the other sectors, and I focus on health. And that's what we're going to be doing today. In addition to that, we have 6 regional offices that help us work with policymakers on the ground in a more detailed way on a daily basis. And those are based at universities, respected universities in their respective regions. That's just our work. Our ultimate goal is to achieve impact. So this is a conservative estimate, 200 million, of the number of people we believe have been reached because of the scale up as a direct function of the evidence generated by our research. And as you can see in this slide, I hope, is that most of this is actually related to health. A scale up of deworming programs because of the research done by our affiliates, chlorine dispensers, and other programs that focus on, for example, rice subsidies or community block grants for maternal and child health. Some of the impact can be quantified and some cannot. And I'll be talking in just a moment about the influence that our research has had on the free distribution of insecticide-treated bed nets. Now, if we just zoom in on the health sector, you can see that of the 800 or so studies, a very large proportion are focused on health. There are nearly 200 studies in nearly 4 dozen countries, and they cover a very wide range of topics. As you can see, a large majority focus on maternal, newborn, and child health, which I know is important to the Canadian international development community. And I did a count before I came, and approximately 75% of all of our studies are focused directly or indirectly on that topic. But what you see is there's a great diversity of topics that are covered, and it's because our economist affiliates are not coming to the health sector from the perspective of saying, I want to dedicate my career and my research to the topic of water and sanitation or nutrition, but more some type of an economic or behavioral perspective on a topic that can then be applied across multiple sectors in some cases. So they don't always work on health, but within health, they often work on different topics. So now we'll move into the evidence. So with that in mind, let me show you the 6 different themes around which our evidence is organized. There are 6, and we say up front that these are not the most important necessarily, or certainly not all of the different themes that you would want to address in health. They're the ones for which our academic leadership has determined there's a sufficient amount of evidence so far that we can say something cogent about what types of policies we want to think about scaling up. And you can see that it's not organized by HIV or child health. It's organized by economic or behavioral type of intervention. So the first that we're going to focus on is pricing, and particularly around preventive health products. The second is the use of incentives, whether they're financial or in-kind, or nudges, ways in which to change people's behavior so that it's more health promoting. And the third will be information campaigns. How do you want to think about rolling out an information campaign to maximize the likelihood that it will have an effect? The fourth theme will look at provider performance, so healthcare clinicians and nurses, and how do you get them to attend and show up and provide good quality care. And the fifth theme is about school-based interventions as a way of capturing more children and achieving the spillover effects of getting more of them at one time. And then finally, early childhood development, which is cross-cutting in many ways across these themes and types of interventions. The one thing I'd like to say about what constitutes the body of evidence in this is that this is not a systematic review with a very clear set of inclusion criteria. It is a review under the guidance of our co-chairs, and they decided that they would only include randomized control trials that are primarily coming from the discipline of economics. That's our comparative advantage, and it allows us to set a very common methodological rigor or bar to what was included. But it doesn't mean that there's not a lot of very high quality quasi-experimental studies and other types of research, including qualitative, that are important to capture, but we wanted to set clear parameters for what we're including in this analysis. So let me jump right in by discussing theme number 1. So preventive care is really important, clearly, not just for me as the user, but oftentimes because there's considerable spillover effects in terms of public health by me preventing myself from getting a disease. And these can often help to interrupt the disease transmission cycle, and they're often quite cost effective. So for in resource-constrained environments, in health sectors that don't have a lot of resources or capacity, preventing disease is going to be much more cost-effective than treatment. And you can think about that very concretely in terms of something like diabetes or cancer. Unfortunately, take-up of preventive products in a lot of developing countries remains really low, even though they can be very, very low-cost types of technologies, such as chlorine, which costs pennies per household per month, but people still don't use it. And so we have to ask this question, why are people more likely to spend on treatment than they are on prevention? And it gets to this economic theory that for types of goods for which private individuals will underinvest, subsidizing those goods has good theoretical compelling argument. The question is how much to subsidize. That's what remains controversial. And so for decades, there's been very strong convictions on either side of this debate. Consumers should share in the costs and pay user fees. Otherwise, they'll take it for granted or they won't use it. No, they should get it for free. So this is the debate. How much to subsidize? And there are really strong, compelling, logical arguments on both sides. On the side of cost sharing, for which many organizations have advocated for decades, is this idea that with a fixed budget, if you bring in revenue from people, you will be able to allocate that amount of money over a wider number of people. And the people who you're then able to reach, you're screening in people who will need it the most, who will value it the most. If you exhibit a willingness to pay for a product, you're more likely to expend the effort that's required to use it. And then in addition to that, there's this idea there's this argument that if you give things away for free, you will generate a culture of dependency where they will always expect it for free. And what do you do when the money runs out and you're no longer able to do that? And you don't help to develop private markets for these goods. And then finally, just a very simple and clear idea that if you bring in revenue, you help with the financial sustainability of your program. All very sound arguments. I could easily design my policies based on those. But then on the other side, there's this idea that if I charge prices for these goods, I'm going to screen out the people who need it the most. Not only the poorest people, but the sickest people, because often those two things are highly correlated. And it also will encourage take-up. If you give things away for free, it's not surprising that more people will take it up. And in a context of positive health spillovers, that's going to be really helpful for public health externalities. And then finally, this idea that, well, just because you give something away for free doesn't mean people don't value it. They could use it. Sometimes I get free trials and I still use them. So the thing is that we've had this debate for a very, very long time. And what do you do in the absence of evidence? You just implement policy based upon your intuition or what you think rationally is probably what people are going to do. So what our researchers did over the past 15 years is they conducted a whole suite of studies around pricing of these types of products. And if you can see the screen, it covers a wide range of different products: deworming, insecticide-treated bed nets, soap, water filters, latrine slabs, and so forth. And what you find on this graph is very compelling evidence, all going in the same direction, that if you even charge a very small price, you see dramatic drop-offs in take-up or adoption of these products. And these prices are often a fraction of the market value. So they're already highly subsidized, but people are not willing to pay for it. And this is perfectly in line with a theory that I'm less likely to invest in prevention than in treatment. And there's reasons behind this that we can talk about. There's different competing theories about why this might be the case. Now let's zoom in on one particular product and share some of the lessons that are coming out of this suite of research, using malaria as our example. So I hope you can see this graph. This is a study that was done about 10 years ago in Western Kenya, in which they worked with health clinics, and in particular with pregnant women getting antenatal care. And they randomized these health clinics into 4 different groups that received malarial bed nets for the pregnant women at different prices. Some clinics randomly offered the pregnant women the nets for free, some at some price between 0 and 60 cents. And these were at 4 different price points. 60 cents represents a 90% subsidy in this context. So we're talking about almost entirely subsidized to highly subsidized, to completely subsidized. And even at 90% subsidy, you see a drop-off of 60 percentage points just for the cost of 60 cents, which is not even a lot of money in this context for a durable product that'll last you for several years. So that's the first main policy lesson that's coming out of here, is that because you have these potentially steep drop-offs in take-up, you actually could have a program that doesn't allow you to get the health effects, because you need a certain amount of coverage to realize the positive health spillovers, but you're not achieving that. But secondly, it can become more cost-effective, because then you have to spread the fixed costs of implementing the program across a much larger number of people. In addition, this study did something very innovative. What it did at baseline was it measured the anemia status of all of the women, and then it found that women who were anemic and who therefore, which is an indicator of malaria, and who were therefore appeared to be sicker, were no more likely to be willing to pay for a bed net than those who were not anemic or who were not sick. And so cost sharing doesn't seem to screen in or allocate the products for the people who you would think would value it the most. And in addition to this, they did something very interesting. So within a particular set of clinics that received the price, let's say, for the bed nets of 60 cents, they would offer all of the pregnant women in the clinic the Bednet for 60 cents. And then once they said, yes, I will buy it at that price, they then randomly selected a subset of those women to receive the Bednet at a further discount. So let's, for example, say 30 cents. What this did was it introduced an exogenous change in the price among a group of people that all exhibited the same willingness to pay. So in other words, you had a room full of people that were all willing to pay the same price, but then randomly some of them were selected to receive a further discount. And what that did was it said that some people paid more and some people paid less, but they were all the same type of person. So they were all the same, showed the same willingness to pay. And what they found is that when they went back to their homes 6 months later to see whether the Bednet was hanging as a proxy for usage, there was no difference between the people who paid more and the people who paid less. So just remember that this is the same type of person, the same expression of willingness to pay, but those who paid more were not using the Bednet at a higher rate. That's a little complicated. I hope it made sense. And then, sorry. Okay, so then there's this question that I raised earlier in the debate, which is that if you give something away for free, what happens to people's demand later on? So they did a follow-up study, and this time with a larger set of households, so the general population, and they offered these households a Bednet at some type of a different subsidy level, from free to 40% subsidy, which equated at that time to about $3.80. And they did it this time through a voucher. So in addition, instead of being asked as a pregnant woman in the clinic, do you want to buy it right now or not, they received a voucher that they could redeem for up to 3 months. And then what they did was, and this was a new type of Bednet. It had never been on the market. It was more comfortable, higher quality. So it was an experience good, something people could learn about. Then what they did was they went back a year later in phase 2, and they offered all of these households the opportunity to buy a second Bednet, but at the exact same price at $2.30 for everybody. So some people were being offered to buy the Bednet at a higher price, some at a lower price. It was still very heavily subsidized. And what they found is that those that had paid less, 75 cents or less in phase 1, were more likely to pay the $2.30 in phase 2 than those who had paid more, which might seem a little counterintuitive, but if you think about the fact that people were able to learn about the quality of the product and that it was comfortable to sleep under and that it protected them from malaria, that they otherwise would not have bought it because it wasn't for free. They took it up because it was not expensive. They actually learned about it, and then they exhibited a higher willingness to pay later on. The caveat I want to make to this is that this isn't true for every good. You have to think about the type of good. This is a good in which people were able to learn about the benefits that were immediate and positive. If you're thinking about some type of a good like chlorine that might change the taste of your water, then if you can't figure out that chlorine then prevented diarrhea for your children, then you may not necessarily associate that with something that you would want to pay for later on. So it's always important to think about the product and the way that people experience it in whether or not this particular policy lesson would hold. But it's important to recognize because sometimes people think that if you give something away for free, people will not be willing to pay for it later. Okay. Right. So the last thing I'll say in this theme is basically that, as we've discussed, because preventive products have very positive spillover effects on health, and because people are very unwilling to pay for them, because the private benefit is often very low, then these types of goods warrant an ongoing large subsidy for most of them. And I've given a couple of examples here of the types of spillovers and how significant they be. So there was a study, for example, that showed that if you lived within 500 meters of a population in which 50% of the people were using a Bednet, you had an equivalent amount of coverage from malaria, even though you weren't using a Bednet. And that's pretty dramatic. And because you don't always need to achieve 100% coverage to get the large, vast majority of the public health spillovers, you may not need to subsidize to 100%. So that's my very last policy lesson here. The others we've discussed. That is that as a policymaker, you need to think about, it would be nice to give everything away for free, and we've given you evidence about why that's important for these types of products, but if your resources are constrained significantly and you're not able to, then you can try to think about at what level of coverage you need to achieve and try to hit a subsidy level that would get you there. And at least you'll be able to reap most of the positive health spillovers from that. Okay, so our main policy recommendation for theme 1 is simply that you want to subsidize cost sharing. That if on this debate, we have clearly landed with a body of evidence that shows that giving mass free distribution of these types of preventive products is very, very helpful in terms of sustaining long-term adoption and use of these types of products. And as I said, we're focused on preventive products. Okay. And then finally, this is a nice little GIF of two different pieces of data. One is the increasing coverage of anti-malarial bed nets in sub-Saharan Africa over the past 15 years, and the correlation that that has with a decreasing incidence of malaria among young children. You can even see that it's highly correlated within parts of sub-Saharan Africa, like West and Central Africa. And this really started to happen after this evidence came out, and organizations started to move in the direction of mass distribution of free bed nets. It's a function of the public health community effectively citing the evidence that's been generated in this set of studies. So this is an example of evidence informing policy. Okay, so thinking about theme 2 is really nice when we think about behavioral economics, and many of the types of interventions across all of these themes are using some type of behavioral mechanism to change either the consumer or the provider's behavior. Conceptually, I want to give you a couple of ways of thinking about this. So in the last example, every individual has to make a cost-benefit analysis about whether to invest in a preventive health product. And if I reduce the price, I remove some very small piece of the cost, and then I hopefully tilt this little seesaw in the direction of, yes, the benefits are greater than the costs, and therefore I'll invest. In this case of incentives and behavioral nudges, I'm adding a very small benefit to do the exactly same thing. So in the last example, cutting the price down to 0 will get me lower the costs. In this case, I'm doing negative pricing. I'm getting the price below 0 by providing some type of a benefit, whether that's money, whether it's an in-kind incentive, or some type of behavioral nudge that gets people through the barrier of procrastination, or it's inconvenient, or impatience, something like that we have, some psychological response. So I want to give you another way of thinking about this, just to kind of make it really clear before we start. So here you have on the y-axis benefits, and then below the x-axis costs. And then you have time on the y-axis. And if I have to make a decision to invest in some type of a health product now, in this case a service, let's say I want to vaccinate my child, I'm going to incur some type of a cost. That cost could be having to walk to the clinic, and perhaps I find it closed and have to walk again the next day. Or maybe it's the actual monetary cost of the transportation to get to the clinic, or it's leaving my other children behind, or not being able to work on the farm. You can think of many different reasons why I'm going to incur some cost to going to vaccinate my child. Now, I don't get a benefit today of vaccinating my child. I get a small one tomorrow because him or her, they may or may not get infected with another disease tomorrow, or the next day, or the next day, or the next day. So it's a very small benefit over a very long period of time, but I never see the benefit because I don't see that my child doesn't get sick because I vaccinated him or her. And so what do? I say, I'm going to just wait. I'll wait till tomorrow. It's procrastination. So what happens tomorrow? Well, tomorrow becomes today. It's the exact same cost-benefit analysis, and this is why we as human beings keep pushing things off that we don't want to do when they incur some cost. So what can I do today? I can go ahead and change that calculus of that individual by providing a benefit that's equal to or slightly greater than the cost. And by doing so, I trigger a behavioral response that, okay, I will not no longer procrastinate because I can do this today. When you approach a study from this perspective, then you actually learn something greater about people's human behavior. And so I just want to make the point, as probably Iqbal did, that our researchers are not just a program evaluator, not somebody who's just going to tell you program A works better than program B. They bring to this field and to the questions that you're asking a very rich body of literature and theoretical understanding about what they want to learn that advances not only the policy question, but also science, so that we try to answer questions that are larger than whether a program worked or not. So I'm going to give you a program example to make a larger policy lesson point. Sorry. Okay. So let's think about water and sanitation. So we know that hundreds of millions of people don't have access to safe water, and if they did, we would save more than 500,000 lives every single year. But even very low cost, easy to implement technologies, demand is very low for. So what should we do? Well, there was this very interesting suite of studies that took place in Kenya a few years ago. Very, very complicated RCT, many different arms, most of which I'm not going to mention, but in effect, one of the treatments was to provide free chlorine bottles at home for people to use, and then followed it up with coupons and vouchers that provided steep discounts for them to get a new bottle of chlorine every month for a year. And then they overlaid these interventions with different types of information and persuasive messaging. And then they implemented the vouchers at different degrees of intensity within communities, and then measured to what extent adoption diffused through social networks, which they mapped. So as you can see, it's a very complex study. One of the arms was to provide a point-of-use chlorine dispenser that you see in this image at the place where people collect their water. Very, very simple to use. And they combined it with a paid promoter, somebody from the community who would go and speak with the rest of their neighbors and tell them how to use it and why they should use it. All of the other treatment arms, whether you tried to give it away for price, whether you gave steep discounts for the future, whether you provided information, whether you tried to diffuse it through social networks, there was no effect on adoption. This is the one arm that really changed people's adoption of this. It increased the take-up of chlorine from 7% to 60%. And the take-up was sustained 2.5 years later, even after the promoters were no longer paid and active. So how could this be? People were not responding to price. I mean, it was cheap to begin with. You gave it away for free. It didn't really change things. They didn't respond to information, whether it was provided by the researchers or whether it was provided by their neighbors. What they responded to was a set of different behavioral nudges that this intervention provided. The first was that it was convenient. You're going to collect your water anyway. The chlorine dispenser is right there. It's really easy to use. You just turn it once and you're done for a 20-liter can. There was a visual reminder, so it was always there to remind you that you need to do this. But in addition to the paid promoter giving you reminders and encouragement, what really was happening, and this is all the hypotheses of the researchers, is that you had social learning. Because two women would meet at the chlorine dispenser and they would share information, how to use it, why to use it, what the effect was on their household. And then you had norming, changes of behavior at a community level, new social norms, habit formation. One example I like to give is that I don't think about brushing my teeth. I was taught to brush my teeth when I was a very young child, and I do it every day, and I don't cognitively spend energy on should I or should I not do this. And eventually what happens is people just go to the water to collect their water, and they just use the chlorine dispenser. So I was in Kenya last year, and I saw one of these chlorine dispensers, and a young adolescent girl came up to fill her water, and she just naturally did it. She didn't think about it, she just naturally did it. But 2 years ago, she wouldn't have done it, and she certainly wasn't thinking about whether should I do this or should I not do this today. So you change people's social norms behaviorally, and this is often a nice way of intervening without a financial cost. Now, one of the examples that Iqbal had mentioned in February, but I think warrants going through again, is this really nice proof of concept study that took place in India about 10 years ago. So I'm going to go through it for the sake of everybody, but basically what the researchers did was they went into Rajasthan. Now, at the time of this study, only about 44% of children had full vaccination in India. But in these tribal, remote, rural areas of Rajasthan, the actual full immunization rate was around 3%. So an extreme outlier in the negative direction. And so what they did was they created a 3-arm trial with about 134 villages. One group served as the comparison group, which basically meant you're just going to continue under the status quo. One group, they tried to alleviate the supply problem because, as we'll see in going forward in the talk, a lot of the health clinics in this context are closed. And so they created these camps where there was a reliable supply of vaccination because they'd show up, let's say, every 4th Wednesday for 4 hours, and you knew they'd be in the village and you could get vaccinated. The third treatment in this study was basically giving those camps to alleviate the supply problem, but also thinking about, is there a demand problem? Is there some reason that my mother doesn't want to vaccinate her child? So they provided incentives. And in this context, it was a kilo of dal, or lentils, which, as you saw in that conceptual model, just offsets the slight cost of bringing my child to get immunized. And this is what they found. So across the x-axis is the number of vaccinations to get you to full immunization. And you can see that even in the comparison group, half of the parents will vaccinate their child. So there's not some deep barrier or cultural resistance to vaccinating my child. They want to do this, but something behaviorally happens. Something with that cost of immunizing my child makes the parent drop off throughout the schedule. And you can see that it falls to just 6% by the time you get to the 5th vaccination, which, as you know, happens after a full year. So there's a persistence problem. The camps in the yellow solve the supply problem and get you part of the way there. You've tripled the rate of vaccination, but when you add these incentives, which are very low cost, you really help with persistence. You can see that at the 1st and 2nd vaccination, the supply and the supply plus demand interventions give you about the same amount of vaccination, but then the 2 lines really diverge. And the incentive is something that behaviorally gets people over the persistence problem. And so here it is again, where you have the 3 different outcomes. You have the 6%, 18%, and 39%. What's really interesting is that when you provide the incentives, it's a more cost-effective program than when you do not. And that goes back to my point earlier that you're taking these fixed costs you have of providing the camps, but you have so many more children getting vaccinated that you therefore have the cost per vaccination at half the price of the child when you don't have the incentives. So even though you're expending more money for the lentils, or the small incentive would be the larger point, you actually have a more cost-effective program. And what's important is when you're at 39% coverage, you're much closer to that coverage point you need to break the cycle of disease transmission. So it's more cost-effective and it's more effective in realizing your public health spillovers. Okay, now I'm just going to take an aside quickly before I go to theme 3, and that is that this study is now being replicated in several different countries. So it's being replicated in other parts of India, in Sindh province in Pakistan, and in Kenya, and in Sierra Leone. And they're all doing different things. And I'm going to zero in Sierra Leone for a moment. But once you learn something like this, then that takes you to the next iteration of research. And so they're saying, well, do I want to give the same incentive at every single vaccination across the schedule? Or do I want to have a slope, an increasing slope, where the incentive becomes greater every single time? And do I want to do it with an in-kind incentive, such as lentils, or cash, or quasi-cash through phone credit? In Pakistan, they're actually doing a lottery, so instead of a guaranteed incentive that you get, you enter a lottery to win a larger incentive. So they're also overlaying onto the incentive program SMS messages. So you can see how the researchers build on one piece of research to the next to try to answer different design questions. So once you establish that small incentives work, then the question is, how small can they be? How low can I get to get the same exact effect? And what type of incentive and how does information complement or doesn't complement the incentive. So you can take different forms. Now, I'm going to go ahead and give you an example of how we think about external validity and how we try to think about whether or not a program is generalizable across contexts. So let's say, for example, a government in West Africa says, I really want to improve my immunization rates. Should I do this type of a program? Well, here's all we know. We know that in this one study, incentives for immunization led to higher completed vaccination rates. We have one randomized evaluation from South Asia, not from Africa, and it was conducted by an NGO, not a government. So how do you use this evidence? You need to think from a theory-based approach, and you need to ask questions in your theory of change about whether all of the steps hold. So in this, we have the basic local conditions that you have an incentive program and parents want to vaccinate. So we saw in the last example, we know parents want to vaccinate. They just have a persistence problem. Is that the case in this West African country? In this West African country, is there a supply problem or not? If there isn't, then you don't have to have a supply intervention like these camps. Maybe they already have a system in which you can access the clinic, it's close by, and the providers show up for work. The behavioral type of part of the theory of change, we know from the literature. We know that people procrastinate, and we know from a whole body of research that small incentives help to overcome this bias, and that completing a schedule can be made salient through an intervention. Then you have a process question. Can you actually get the incentives to the clinics and in the hands of the parents? This is where a really important process evaluation and implementation measurement is important. And then finally, questions around the impact. So we'll come back to this in just a moment. So now let's say you have two countries in Africa, and these are the immunization schedules from DHS, for example. Which country do you think would be more appropriate for this type of an intervention? It's probably country one. Country one is showing you that parents want to vaccinate. 84% get the first vaccination. But you can see this drop off, that something's happening where they're procrastinating or whatever, and you know this. Now, you know from qualitative research, because you've worked in this country before, that their supply is not a problem. So we're talking about Sierra Leone. After Ebola, many people, the government expressed a lot of concern that people were no longer coming to the clinic and immunization rates were dropping. So they said, we need to get people back into the clinic. And so they wanted to do an incentive program. So if we think about the Sierra Leone in context through theory and not whether or not it matches along some type of a demographic indicator, we can say, what do we know about the local conditions? Well, we know that parents want to vaccinate, and the government and all our research shows that, yes, supply is not a problem. We have plenty of evidence on the behavioral linkages, so we're set there. We do have a big question about whether or not we can actually deliver, whether we can implement this without leakage and we can do it in a cost-effective way. And then finally, yes, we can then measure the impact in the theory of change. So instead of doing a randomized control trial in Sierra Leone, we're doing a logistics pilot. We're actually working with the World Food Program, and they're providing an incentive through the form of food because their agenda is better nutrition, and they're doing it through pregnant women, so the women will get an amount of food for every antenatal care visit they go to, and then after the birth, continue to get that while they go through the vaccination schedule for their child. What we're really trying to measure is, can we actually implement this well with a government? But what they've decided to do is overlay this with another randomized evaluation. And what they want to test this time is a different type of incentive. Rather than it be financial, can it be a social incentive? And it's in the form of bracelets for the mothers to see whether or not that gives them social status in the community by sending a signal to their peers that, yes, I'm taking care of my child and having him or her vaccinated. And so you have another opportunity to learn something new. So that's one small example of how you would think about adapting a program and the lessons from one context to another. Okay, so these are the main policy lessons that come out of theme 2, and I gave you some examples and evidence from the access and nudges. We haven't talked about cash transfers, but that's another policy lesson that should come as no surprise, have been quite effective in improving health outcomes. Okay, so for theme 3, I think this is important because we spend an enormous amount of money in the development community on information campaigns. So I was speaking with some of your colleagues here this morning with the statistic that I always cite because I think it's so compelling, that the Indian government spent $400 million in 2012 on information campaigns, on water and sanitation. So I just think that's amazing that that amount of money was spent just on information and just for water and sanitation in 1 year in one country. It should tell you the vast amount of money that's being spent. So why do we think that information is so effective? Well, there's different theories. One is people don't have knowledge about the benefits of a particular technology. They may not know that chlorine helps their child not get diarrhea. They may not know that using a condom interrupts the transmission of HIV. Now, there also may be the fact that the health threat itself is not salient. So I may not take the necessary precautions to prevent Ebola because I'm not threatened by Ebola in Boston. But I am threatened in the winter by the flu. And so I wash my hands more frequently in the winter than I do sometimes in the summer. And I think that's a behavioral response that once the threat goes away, I go to a behavior that's less costly. And then thirdly, there's really deeply entrenched social norms. And the perfect example of this is open defecation, which is most prominent in South Asia. And since everybody does it, and it's the way my grandfather did it, then this is what we do. And you can't necessarily make the link, so this goes back to the lack of information, between my practice that my entire community does and the negative health outcomes we have. And so these are the reasons we think information matters, but we don't always know how to deliver it. And I don't have all the answers today at all. We have some evidence about some ways in which you want to think about information, but there are a lot of open questions about this. The first, probably most important lesson is that exhorting people to do something doesn't really work. You can't just tell people, do this and don't do this. Now, it seems obvious to many people in this room, but a lot of programs are structured this way. So there was this interesting mass media campaign at the provincial level in Peru to tell people to wash their hands. So they had public brochures and they had radio campaigns and TV ads and everything. Not only did this not change people's behavior, it didn't even change their knowledge. People didn't even incorporate that knowledge about this from all of this information, let alone change their behavior. Another example I'm sure all of you are familiar with is abstinence-only HIV sexual education. So this is an interesting example that I wanted to bring up because there's another study embedded within this. So this, in Kenya, at the time of this study, had the 11th highest rate of HIV prevalence in sub-Saharan Africa. And they had a national curriculum of sexual education for upper primary school students, but it was focused solely on abstinence. It did not teach them about relative risk reduction strategies like condoms. And so what they did was they enrolled about 300 different primary schools, and half of the schools were randomly selected to send teachers to a national training. Then they would come back and train their 8th grade students in the national curriculum, which was abstinence-only focused. It didn't have any change in sexual behavior or childbearing rates or anything. In a subset of these 300 schools, they introduced an intervention that they called the relative risk intervention, in which they provided very specific information on the HIV prevalence rate in the local community, disaggregated by age and sex. Now, we're in the context here of sugar daddies, so a lot of these young adolescent girls are having sex that's quite transactional with older men for a number of reasons. And because of that, they are exposed to a higher rate of risk for HIV, contracting HIV, because the older men have a higher prevalence rate. But they didn't know this. And so when they were presented this information through a video and then given data by a trained expert from the outside about the prevalence rates in a nearby city, they changed their behavior so dramatically that there was a 28% decrease in childbearing rates, and this was entirely a function of a reduction in cross-generational sex. So nothing changed in childbearing with peers, but it dropped by 61% with men 5 years or older. So they incorporated this knowledge very much, and the reason is because it was specific and it was actionable. They could easily switch the partner that they had. This wasn't saying don't have sex, it was saying change the person with whom you have it. And this really changed the outcomes. So another example of this idea that this policy lesson is coming out is that about specific and actionable information relates also to HIV. This was a study also in Kenya. They had 430 adult patients who were newly on ART, and they divided them up into 4 groups in which they tried to help improve treatment adherence to their medication by giving them SMS messages. And the 4 treatments were, some people received a daily message, some people received a weekly message, and then cross-cut with that, some received a short message, and some received a long message. The short message basically said, take your medication. The long message said, take your medication, we really care about you, or you can do this. So it was more encouraging and empathetic. What they found is that if you just provide somebody, in this case it was a weekly message that was short, it increased the treatment adherence by 40 to 53%. So quite dramatically, and that it decreased the interruption between treatment, let's say missing your medication for 2 days or more, from 90% to 81%. And this is important evidence because it's not, on the face of it, you wouldn't know that you should do it weekly over daily. In this case, the authors hypothesized that it was too frequent of data, and so it was overstimuli, and people became immune to it. And you wouldn't think that the short message would be as effective as the long message. So this is an example where it's specific information and it's actionable. This is just a picture of the cap of the pill bottle in which there was a sensor. So when they went to go refill the medication, the nurse would take the cap and put it on this measurement tool and upload the number of times that the bottle had been opened as a proxy for how many pieces of medication were taken. So it wasn't self-reported. This is just another innovative measurement tool. Okay, so for the sake of time, I'm going to move through this a little quickly. There is some evidence on how information is delivered is important, and it's mixed. Sometimes positive framing of the health product is good, sometimes contrast framing, meaning that if you do this, it's going to turn out good. If you don't do this, it's going to turn out bad. But this is mixed evidence, and so we have a lot of open questions about how do you appropriately frame information, positively or negatively. Medium of information, so how do you deliver it? Is it through a community workshop? Is it through a play or a story that the community tells? Is it through the radio? Is it through printed materials? And who delivers it? Is it done through the local religious institution or through the school or through a trusted leader? This is an area of research that I think we don't have any strong evidence. So the main policy recommendation for this theme is basically that you want to provide specific and actionable information for interventions that don't require large switching behaviors. Now, we've talked about a couple of examples. This would not necessarily apply for smoking or something for which people have addictions because the switching cost of behavior is very high. So a lot of interventions that try to get at smoking or other types of very significant behavioral entrenched behaviors, they often overlay information with some type of strong incentive. Okay, so I'm going to move to theme 4 because I've got about 10 minutes left. And these will go a little quickly. So with providers, we know that we have very significant problems in developing countries, both with attendance and quality of care. So in this Rajasthan example that I was telling you about, when the mother has to decide whether to take her child to get immunized, at the time about 44% of the clinics were closed on any given day, and you didn't know when it was going to happen. This is the case in Uganda, where about 50% of the clinics in this research study were closed at any given moment at baseline. Now, community monitoring and more broadly community-driven development is another area of very large investments. And for this, we find that the evidence generally shows that it doesn't work. There's one notable exception, and it's important to think about why there was some strong positive impacts on this. So as I said, this study was done in Uganda. And what they did was they went to about 50 public health dispensaries and divided them up into a couple of groups. The first group was your comparison. The second group was your treatment. And they did baseline surveys of healthcare conditions, the quality of care, things like waiting times and absenteeism rates and things like that. And they created these report cards. And then the community was given the report cards, which provided very local information. And there was a series of 3 different meetings. The first meeting, had the community members come and talk about their grievances and what works and what doesn't and what needs to change. The second meeting did the same similar thing with the providers, and the third meeting was an interface meeting where the community and the providers came together and developed a local action plan that they would then implement and monitor. And what they found was when they measured utilization of services, quality of services, and health outcomes, very dramatic positive impacts on things like absenteeism, waiting times, utilization of healthcare went up by 20%, and a lot of health outcomes improved as well, including under 5 mortality, which dropped by 1/3 in this context. And so they went back and they said, that's amazing. Can we do it without the report cards? Can we do it solely through these meetings? And what they found was no effect when they went back and only provided the participation, the community meetings. And the theory behind that is that you needed this local information to develop a local action plan. In the second phase, when they just had the meetings, the providers, they just complained that they needed more money and more resources from the central government. But absent that being able to happen, there was no way to make change. It was only when they came together and had local information on the problems and developed an action plan that they could then change on their own, independent of whatever the health officials could do, was when they achieved an effect. All right. I'm going to skip this just for the sake of time. There's other policy lessons that come out of Theme 4 for which I don't have time to discuss, but I'm always happy to continue the conversation. In Theme 5 in school-based interventions, very simply, we think that there's a reason to go into schools, to extend healthcare beyond the health system, partly because schools are more ubiquitous than health clinics, there's often more convenient, and it's a great catchment area for a large number of children. Teachers are, on average, absent half the time of health providers, so that helps as well. And it also helps because teachers can be a conduit of health information that parents may not have, helping to correct some misconceptions that caregivers at home have and help to make further investments in health. Now, there's been a lot of different health interventions in schools, some of which we've talked about, like this HIV risk reduction program, but I'm going to focus just on deworming today. Now, one of the most seminal studies that's come out of our researchers' work is a study called the Primary School Deworming Project that was done in Western Kenya in the late 1990s. It was a pricing study in part, but it also was basically just seeing whether or not if you give mass distribution of deworming in schools, can you change school student attendance? So student attendance was very low, and when they did the qualitative research, they asked the teachers, well, why is that? Well, the school's not good. I need more resources. I need more textbooks. I need more desks. I need more money. I need more training. When they went to the parents, they said, well, my child's not going to school because they're often very tired and lethargic and sick, and they don't have the energy. So they went to the health clinics and said, well, that's not a surprise. Most of these children have very large worm infections. So all of these common wisdom approaches to improving student attendance, whether it was providing more inputs or smaller class size rooms or things like that, no one would have ever thought that actually if I dewormed children, I could actually get not only the health benefit, but I could also get better school attendance. What they found in a cost effectiveness analysis was this was by far the most cost-effective way of improving student attendance in schools. So they replicated the study at the preschool level in India, this time combining deworming with iron, and they found that once again, this was as effective in terms of a 20 to 25% increase in student attendance in both of these contexts. This gave range to a whole range of different studies and follow-ups. It's part of now what's called the Kenya Life Panel Survey, and they followed these children 15 years on. They're now young adults, and they've looked at their outcomes from being dewormed as a child versus not being dewormed for as long of a period, and across a whole range of outcomes, they're doing much better. But they've also looked at spillover effects on other people that were not dewormed. So this was a follow-up study that somebody did about 10 years later after the program, and they went back and they looked at the cognitive development of now, I believe, 10-year-olds who were at the time of the program under age 1, but they lived in the communities that were treated. And what they found is that if you were in one of the treatment communities, you had a 0.2 standard deviation higher cognitive skills than those who were not. But you weren't dewormed. but you had the positive spillover effects of the people around you not having as high of a worm infection. If you had 3 siblings or more in the primary school, that effect doubled. So that's just one example. Another example is that the girls over age 13 in the schools that were treated were not given deworming pills because there was a fear that the medication that was given at that time could interfere with pregnancy. And there was a possibility that girls of that age were not just of reproductive age, but sexually active. So they didn't give them the deworming pills, but they also had lower rates of worms and higher levels of educational attendance and outcomes. So this is an amazing suite of research that shows the effect of school-based interventions and positive spillover effects and long-term outcomes. This has been scaled up to about 100 million children around the world. These are some of the emerging policy lessons, of which I've only been able to go over a couple of them, but I'm sharing this presentation with you. And in high workload context, our policy recommendation is to implement mass deworming. So the final theme in the last 5 minutes is basically to think about interventions around early childhood development. So early childhood development has dozens of different types of interventions and a massive amount of research and evidence, mostly though around short-term impacts. So what our researchers have decided to do is focus this presentation solely on those studies for which there's long-term impact. Evidence of long-term impact. So this is just the motivation of why we care about early childhood development. And it should come to no surprise to anyone in this room that there's a lot of children with a lot of need, and there's a lot of important outcomes that go on forever. If you don't invest very early on in those first 1,000 days, you can have long-term impacts on cognition, educational attainment, attachment, behavioral responses, and so forth. So that's the motivation for why we care. And probably some of the most compelling evidence is around the importance of psychosocial stimulation for very young children. One of the most important studies that was ever done on this topic was in Jamaica. It was an RCT in the capital in the mid-1980s with 130 children who were very low income and stunted. They divided them up into 4 groups. So there was a nutrition arm, which they received some formula, a stimulation arm, stimulation plus nutrition, and a comparison group. Long story short, they followed these children through the ages, and now they're in their probably about 30 years old, and they're still measuring them. The World Bank just commissioned another follow-up study. They have found that at every stage of life, they've done better. Cognitively as young children, lower dropout rates as teenagers, higher overall education attainment, higher levels of tertiary education, higher earnings, 25% higher earnings as adults, less criminality, more out-migration of the families from Jamaica to the United States. And so researchers replicated this study. But instead of doing it at this small scale, they did it with 1,400 households at a much larger scale in the context of a conditional cash transfer program in Colombia. We're only a few years out. They're finding the same early to medium-term outcomes, results, very positive in terms of cognition. And so we have produced a new publication that we're releasing this month that this is now a policy recommendation for us. I'm going to skip that because it's basically a study from the United States that's showing something very, very similar. It was an intensive program done with first-time mothers at risk where they would go in and spend an hour or 2 once a week for a couple of years and work with the mother in terms of helping them parent better. I didn't even really say enough about what that program was. I'm sorry. It was outside community leaders coming in and working with the mothers on parenting skills and how to stimulate your child through song and books and toys, and they would leave toys behind and change them out every single week. So that was the actual intervention that helped prompt a higher level of engagement in the home and stimulation. Now, this is a whole set of different types of interventions that help to promote early childhood development, for which we have a lot of short-term evidence. The reason we're not talking about all this evidence and we can share it with you is just because we're trying to focus more on the long-term evidence. So our main policy recommendation for this theme is community agents supporting psychosocial stimulation. Now, these are the 4 recommendations that I've made throughout this presentation. So subsidizing user fees, specific and actionable information, deworming, psychosocial stimulation. There's a lot of other policy lessons that are emerging, but for which we believe a little more evidence in other contexts is needed before we can make it a clear policy recommendation. Having said that, although we have this nice body of research, we've got several hundred completed randomized evaluations in this discipline, we still lack evidence on a range of very important health topics. We still need to do a lot more research on health systems and the big reforms that are happening in developing countries and the impact that's having. Things like mental health are very much understudied. And a lot of the work, as you can see, is focused on communicable diseases. We have less information on NCDs. As you know, this is very important. It's an emerging part of the health disease burden in developing countries. And we want to see whether or not some of these lessons map. You know, if these same type of behavioral or pricing interventions map towards trying to prevent people from getting diabetes or hypertension. And we have a new research initiative that's focused squarely on that I can talk about. And then things like long-run impacts. So basically, the idea is that we continue to have a need to partner together with policymakers such as yourselves in conducting new, very innovative evaluations to try to build this body of evidence. I will stop there, and before I open up the discussion, I just wanted to make sure, in case you have to leave early, that I've set aside a selection of the different publications that we've produced on some of our evaluations. Some are on a single evaluation, some help to synthesize a set of evaluations around one of these topics. 3 of the recommendations of the 4 have a publication that's associated with it that you can read. Did I do okay in time? Okay. So I'll leave a... So I think we'll just leave the floor open. It's nice informal group, small group. Sorry I actually talked at you for so long, but it's for the benefit of the people that are joining remotely. But now we can open it up and try to answer your questions.
In your theme 4, you kind of mentioned or touched a little bit on the role of what I'm going to sum up to be governance and how it plays in the final delivery of programs and aid a lot of times. So as policymakers, a lot of times there is the aspect of theory and then the aspect of practicality. And practicality usually ends up in how delivery happens, and governance ends up being a role a lot of times. Do you have any studies or any work that you may have seen that has been impacted through governance, and how you overcome those, not only from a delivery point of view, but also those that deliver, how they've dealt with that, or if they've even considered governance instead of funding?
Okay, great, thank you. Do I have to repeat the question for the webs? I think they can hear. Okay, so great, thank you for that question. So the first quick response is that we have an entire sector of research that's focused on governance. And we have a research initiative that is focused solely around seeing ways in which we can improve governance, and that can relate to any sector. So short story, yes, there's a whole body of research on this particular topic. Now, within the health sector, yes, that's also true, because one of the things that's very important is that you flesh out an entire theory of change, and you need to make sure that you do a good process evaluation to see whether or not, if the intervention succeeds or fails, it's not solely because of the intervention, but also the way in which it was governed, implemented, and monitored. If you don't do that, then you don't know whether or not the intervention itself is a function of not being implemented well, and whether governance is an issue. But I can give you an example of something from theme 4, because you raised that. So when you're thinking about provider attendance, one thing you can think about is whether you want to create positive or negative incentives. And so there was a couple of studies that were done in India to see whether or not, if you actively monitored nurses or nurses and doctors, whether or not you could improve attendance. And what they found in one study was that In the short term, yes, you can do that. In this case, it was a machine in which you had to punch in as the nurse 3 times a day to show that you were there. But in the long term, over a course of 14 months, the nurses and their supervisors learned how to game it. And the reason was because the supervisors were told to do this by their district health officials above, but they were accountable politically and relationally to their nurses. And so they started providing more discretionary excused absences for them to be able to get away the attendance rules. So I think it's really important, so larger story, when you're thinking about governance and whether or not the intervention is workable politically, you have to think carefully about accountabilities and who is loyal and accountable to whom, and ways in which people are incentivized to respond to their peers. The other one would be that you need to remove discretion of the supervisor to be able to implement or not implement or undermine your intervention. I think that's one small lesson that comes out of the governance work in providers in health, but there's a broader suite of evidence on that. But yes, researchers are actively thinking about that because no intervention is going to work unless you figure out how to deliver it with fidelity in the structure of a scale partner like a government.
Hi, Thomas. Thank you so much for this presentation and all this evidence. I had one question regarding the upscaling of the Jamaican intervention to Colombia. So a study on your website says that so far no impact was found regarding the intervention. That will raise the question about the limitation of RCT and measuring the impact. What's the limitation in your opinion?
Sorry, I'm not quite sure I understand that the limitation of measuring the impact of...
The limitation, okay. So my question is to put the question in the debate regarding using RCT to measure the impact. So I was expecting to see kind of limitations to use the RCT as a methodology and measuring impact. And I'm referring to the example that you mentioned, the Jamaican intervention and the upscale in Colombia.
Okay, so if I understand correctly, I mean, one of the things I wanted to focus on now in this presentation was on the evidence from health, but we could easily have a discussion about the limitations of randomized control trials to measure impact. Methodologically, there wouldn't be one, and methodologically it would be a superior way of finding attribution of the causal impact of your program because you remove all of the biases. With Colombia, I'm not exactly clear what we're talking about because we do have short-term impacts that have been shown of the stimulation piece of the intervention. We don't have long-term impacts. That's just because it's more recent. But we're in the process of conducting more follow-up studies. But if you're talking about the nutritional impact, okay. So what I didn't mention is that in both of the Jamaica and Colombia studies, they did have arms that looked at nutrition. Formula in the case of Jamaica, micronutrient sprinkles in the case of Colombia, and they did not find any impact of nutrition intervention, both in the short or the long term. This is often the case with early childhood development interventions that you don't see an impact of the nutritional interventions. Sometimes you see them in the short term, but oftentimes they dissipate in the long term because people are able to catch up physically, anthropometrically over a period of time. They're not as easily able to catch up cognitively. So in that deworming example I gave where they looked at the long-term impacts of the little babies that were in the treatment communities, there was a persistent cognitive effect of being exposed to treatment in your community, but there wasn't a physical effect because the worm burden doesn't create a long-lasting negative physical impact. So it wasn't a function of the fact of the study design that they weren't able to detect a statistical difference in nutritional outcomes. It was just that the nutritional intervention may not have been strong enough. Even though, for example, they gave enough sprinkles to the family for all of the children, because we know that they're not going to just give the sprinkles to the one treatment child. They're going to want to treat all of their children equally, so you have to give enough. Sometimes it wasn't used, like even at that level, and oftentimes it couldn't overcome other nutritional deprivations they had or other types of environmental conditions like water and sanitation that would lower their physical outcomes. So those are some of the theories about why you saw no effect of those interventions.
I just wanted to make an observation, and maybe you could clear it up for me. When you were talking about the information, theme 3, you talked about some of the struggles that you had with it, but I didn't hear you talk about doing any audience research, or at first starting off trying to understand why people were behaving the way they were behaving, how they best got information, who they trusted the most, all those kind of very basic audience research questions.
So I think that's a fantastic question, and I didn't address it, and that's true. It doesn't mean that it's not done. So every single, we stand up here as JPAL and we often talk about the quantitative results, and this is often what you see in the journal papers as well. Not a lot of time, not a lot of space is given in the papers or even here to talk about the deep bench of qualitative research that goes into every single one of these studies. So many of our researchers work only in a few contexts, a couple of countries, 10, 20 years, for that specific reason, because it's only when they know the context really well, the culture, the economy, the political situation, the gender relations, the institutional constraints, all of that, that they can then design the right study. As you said, to make sure you understand how people receive information, what they respond to. But they never do a randomized evaluation without a year or 2 years of piloting work as well. Because you have to think about, do these survey questions make sense? Does this intervention make sense? Do people understand what you're asking them? Do they understand the information you're providing? So I think I agree with you entirely that qualitative research as inputs, informative research, is deeply essential to the quality of your study, not only at the front end that we've discussed, but also on the back end, because it's only with qualitative research and understanding of the local context that you can interpret the findings and make sense of the mechanisms and channels through which these results are emerging. So I didn't mention it, but yes, it's always a big component of the work that the researchers do, and that's why they often work in the same context over and over.
Hi, thank you for your presentation. I had a few questions actually. So my first question was around, it's also an observation. You didn't talk, maybe it was discussed in the earlier event, about ethical considerations of RCT. So that's the first one. The second thing was around theme 3, information initiatives and social norms. I was wondering whether JPAL has done any form of research around gender-based violence, specifically violence against women and girls, and that at a beneficiary level and also at a policy level.
Okay, great. Did you have a specific question about ethical considerations, or would you like me to just take that on more broadly?
Particularly when you're doing treatments, like how do you make that ethical decision? Like where do you, for instance, when you're talking about the pricing,
yes,
who gets the cheaper one? Like ethical considerations about pricing, or who do you give certain things free, who do you not?
Okay.
Things like that.
Okay, so this question comes up a lot, and there's a lot of ways of thinking about it. So on ethics, the most important thing is that you do not ever want to study something for which you know there's a positive impact. That would be unethical, and that would not pass the test of clinical equipoise. It wouldn't pass the institutional review board that monitors all of this research. You only want to study a question for which the answer is unknown, for which the intervention that you're providing, you do not know whether it's going to create a positive benefit. So to give your example of price, you would have your sample frame, and this could be a universe of people that you want to serve. So you know that at least you're getting all of the people that you want to serve and not including people you don't want to serve, such as the non-poor. When you have that universe of that sample, then you randomly assign them into these different groups. And so you randomly select who gets it for free versus who pays 60 cents. And then you measure the results. It's only then that you would know whether the price changes people's adoption of that product. If you find that that's the case, then you can scale up that finding to the entire group. So that's my very, very base first response. But there are many sophisticated ways of building your study to overcome concerns around ethics. So the first is that there's different types of structuring your research design. One is called a phased-in design, that if you have, let's say, 1,000 villages that you want to serve, but you can't serve them all at once, then one very fair way of choosing the 200 that you can do this year is, instead of purposely selecting them randomly. Because you are choosing people that you want to serve now, and you can't, of the people that you want to serve. So how are you choosing them? You're choosing them for some reason. All we're saying is that if you do so randomly among only the group that you care about, then you're enabling yourself to evaluate and learn from that rollout of a phased-in design. The other is one we call encouragement design, where you provide the product or the intervention to everybody, but to a randomly chosen subset of them, you encourage them through additional information or, for example, assistance with an application. So everybody has open access to the intervention, but some get a gentle encouragement, and you see whether or not that increases uptake. And then in addition to that, you can have a structure where you have everybody get an intervention that you already provide, but then you overlay that with some top-up type of an intervention. So nobody's deprived of anything. You're just testing whether the additional intervention helps to improve things. So the long story of that is there's many ways of addressing that problem, that concern around ethics. And then the last thing I'd say is that when you think about if you think about ethics, I could also easily say that it's deeply unethical for us to be spending billions of dollars on interventions that are not backed by evidence. And we're doing that every single day. If I spend $1 million on a program that is not rigorously evaluated or for which I don't have evidence, that raises ethical concerns for me. Now, on your question around information, I believe, right? It was, can you remind me?
It was about whether there has been studies, randomized control trial, particularly about information or policy changes around violence against women.
Yes, I apologize, yes. So I don't have anything in the completed studies, but there's some really interesting ongoing work on intimate partner violence, and it's been put together as a consortium, and there's, I believe, 7 concurrent randomized evaluations in 7 countries that are all looking at similar types of interventions in different contexts, and they're working together to build a body of evidence around interventions. They're happening at the community level, and they're about, as you said, changing people's norms through information. I know one in particular in Ethiopia that's happening that's very interesting, and it's working with men in a coffee ceremony to try to change and educate them and change norms. So you should see some forthcoming research, but it is an active area. There's a much broader set of research going on gender more broadly, empowerment and cross-cutting issues in different sectors. I think 1 and 2.
I'll start. I just would be curious to find out what you think of similar kinds of work done by other organizations, say like Copenhagen Consensus, will like to use policy recommendations and choices on best, cost effectiveness or cost benefit ratios and things like that. What do you think of their work specifically?
I can't comment on their work specifically. What I do know is that we actually at JPAL recently presented at a conference put together by them, the Copenhagen Consensus in Dhaka, that was looking...
The one that was referred to in The Economist 2 weeks ago.
Yes. Oh, yes. Okay. And there was about the cost effectiveness of different types of programs, I believe focused on gender empowerment. And we were presenting research on a really interesting study going on in Bangladesh and the cost effectiveness of a program designed to delay marriage. I can't speak more broadly on their work or any other institution, but we do partner with many, many different organizations that focus on impact evaluation, for which we respect their work a lot.
Hi there. Thanks for a great talk. A quick comment and then a question. To talk about the ethics of different randomized controlled trials, I thought you provided a great breakdown of the logic. I also think intuitively people tend to think of this two different ways. When you're thinking about someone getting a treatment or not, you can't help but picture their suffering. But when we picture something like a pharmaceutical intervention, it seems obvious it would be unethical to not do a randomized controlled trial. So I try to sort of port over that logic to the different intervention and realizing, wait, we don't know if it works, therefore it would be unethical to do it. The other one was that JPAL provides a lot of great data for organizations like GiveWell, which is a charity evaluation website. I wondered if you knew anything about GiveWell and their approach to using JPAL's methods.
I mean, I know of GiveWell, and I can't speak in detail about the way that they use our data, but so for those of you who aren't familiar, GiveWell is an organization that helps other givers or donors or philanthropists understand what types of interventions or charities, if you will, to invest in. And they do so by evaluating the body of evidence, and they are pretty good in terms of looking at rigorous evidence. And I believe right now they recommend 4 different types of interventions, one of which is deworming. I believe another is about insecticide-treated bed nets. And I think that they basically do exactly what we do, is look at the papers and look at the evidence and read and interpret them through some type of a review of the literature. We also, I should say, make the data, the raw data from these studies publicly available more and more increasingly, and it's required for all JPAL-funded projects. And we put them in an online open repository. So GiveWell may choose to use that data as well to replicate the findings and make sure that the findings are robust. But you see more and more organizations like GiveWell emerging to try to help promote evidence-informed giving. Thanks.
Thanks, Thomas, for the presentation. I'm just wondering, at the end you mentioned there's a few areas right now where there is evidence generated, but you're not yet ready to make policy recommendations. So from JPAL's perspective, could you say a little bit about what it actually requires for you to feel confident to make a policy recommendation? What, how much do you need in terms of evidence to triangulate for a policy?
It's a really good question, and I think one in which our executive committee grapples. So we have 8 sectors, all of which are led by 2 to 3 different co-chairs who provide guidance intellectually and strategically for that sector. And each of that set of co-chairs for each sector determines at what is the threshold at which they're willing to make a policy recommendation. In the health sector, it's 2 or more studies that are conducted very rigorously, very high quality, with results moving in the same direction and in different contexts. The emerging policy lessons where we feel like they need more research, there may be at least one very compelling piece of research that is showing very positive impacts, but where we feel like we need at least another study going on in another context or interpretation. And that actually is a large number of the studies. And that's why the policy recommendations are small. But it's pretty decentralized by sector, and it's not like in the hard sciences extremely systematic in terms of at what bar, because it is social sciences, and it's you're thinking about very carefully about whether it adapts to different contexts. I don't know if that answers your question, but it's not as clean as one might have in medical discipline.
Hi. This question is more technical or methodological concerning how well treatment is administered in treatment and control conditions. I just wondered if JPAL pulls on their quantitative treatment fidelity index. I've read many papers by Banerjee, Duflo, Dupas, and I haven't really seen many details or a mention or reference to this index. Is it a tool that is used now?
So you'd have to make me familiar with it. I'm not. The treatment fidelity index?
Yes, just in being able to determine how loyal or effectively the administration of treatment is in its delivery in influencing a positive outcome. of an intervention.
Okay, so I'm not familiar with the index. I can go and follow up and see to what extent the researchers are aware of it and or are using it. What I can say is that as part of every evaluation, there is a very careful process evaluation that's thinking about, was the treatment implemented according to the protocol? Was it, what is the monitoring? I mean, clearly there's really good, very strong protocols for data collection and analysis and making sure that the data itself is very high quality, but the intervention itself and monitoring and providing oversight to the partner who's providing the actual program, that's something that's done very carefully. Whether they use that particular index to measure it, I don't know.
Okay, thank you.
But I can try and find out and share with Nathan. That's it.
I think that's about all the time we have.
Okay, thank you very much for everything.
Once again, I want to thank Thomas for what was a very insightful and deeply provocative presentation. I quite enjoyed it. Clearly, there's a lot of evidence out there, a wealth of evidence as demonstrated by Thomas within JPAL's work, which we can all access together to help inform our development programming as well as our policies. Not only was his presentation informative, but I think it stimulated a very lively discussion, which I hope we will all continue outside for the reception. Thank you again for joining us. This was our third event of the Measuring Development Impact series, and we will be continuing the series into the fall, be taking a slight hiatus during the summer. But I encourage you to keep an eye out because our next event will be on embracing complexity experiences from impact evaluations with Joe Puri, who is the Executive Director and Head of Evaluation of the International Initiative for Impact Evaluation. So that's 3IE, and that's going to be in September. We also have some cards sitting on the table there that are listing our upcoming events, so I encourage you to pick one up on your way out. Before you leave, I ask that you please fill out the surveys on our sheets just to help give us some feedback and let us know if there's a topic that you think we should be looking into on the subject of measuring development impact. Please let us know. And finally, thank you so much for coming out on this beautiful day. And please, if you haven't signed up for our mailing list, do so and come back to more events. Thank you so much.